And now I have to speak about anemia and myelofibrosis that is really multifactorial because we have many different situations that can interfere with hemoglobin level in myelofibrosis as well as in myeloid neoplasm in general. So one of the first points I think that is the fact that medullary hematopoiesis is substituted by bone marrow fibrosis, as this is in favor of a sort of extramedullary hematopoiesis that can determine splenomegaly and hepatomegaly, but also an adequate erythropoiesis of the extramedullary site, and this can determine anemia. Splenomegaly per se can determine red blood cell sequestration and destruction, determine anemia, an increase of plasma volume, and this can cause hemodilution as well as pregnancy, and this finally determine anemia as well. And the second point is that the changes in bone marrow cytokine expression can determine a milieu for inflammation, and this determined through interleukin-6 and increase impaired of erythroid differentiation that determine anemia again, and also an increase of hepcidin that can determine impairment of iron metabolism. And we know this is very important because we have now drugs that can interfere with hepcidin. And then we have also an accumulation of toxicity related to the red blood cell transfusions. We can have also some loss of blood with bleedings. And finally, in the last year, we had also the effect of JAK inhibitor therapy that most interfere with anemia as well. So anemia is a common problem in myelofibrosis. About 30 to 40% of the patients are anemic at diagnosis, and 60% became anemic during the first year of disease. And more or less 1 of 2 patients became transfusion dependent within the first year, first 1-2 years, and this is a big problem. And we know that anemia is an independent prognostic factor for leukemic transformation and for survival. And this is also associated to some cytopenic profile and to some molecular profiles, such as the low JAK2 allele burden, the presence of RAS-CBL mutation, and also the presence of the U2AFF1 mutation as well. So past year, Teferi and other collaborators within the IVG-ELN group defined the criteria for anemia definition in myelofibrosis. And basically, we generated 3 different levels of anemia, not anemic, anemic transfusion dependent, and not anemic but not transfusion dependent. And so we tested these 3 different groups in the cohort of the Ruxorel in our region, and we studied 288 patients receiving ruxolitinib in the last years. And you can see here that the 3 cohorts, non-anemic, anemic, not transfusion dependent, and transfusion dependent, had a really different overall survival. So the stratification was impactful potentially. And we know also that to be anemic and to be severely anemic implies also a higher risk of blast transformation. The blue estimate represents those patients non-anemic. The green one, anemic between 8 and 10 approximately, and the red one less than 8. So which are the treatment we have now for a patient with myelofibrosis who are anemic? Basically, we can manage the few patients with deletion 5q minus with lenalidomide that is very effective also in myelofibrosis, just not only in myelodysplastic syndrome. We can use not commonly erythropoietin for those patients with erythropoietin, serum erythropoietin level below 500. And for those patients with more than 500 erythropoietin level, we tend to use danazol. And we have now evidence from the Momentum study that danazol might be effective, but in a very low rate of patients. So the information we have is that the rate of patients who are transfusion independent at week 24 was 20%, while at baseline 15%. So the delta of advantage was very, very low. And now we have also the 4 different JAK inhibitor. Ruben provide us a lot of information, so I don't want to go in deep, but we have momelotinib for anemic patient, developing the momentum for the first line, Simplify 1 for the first line, and also pacritinib. I just want to add some information about the Ruxo plus anti-anemic agents, and I want to quote the post-hoc analysis of a phase 3 JUMP study. And in this analysis, 101 patients receiving more or less ESA 898 and danazol-free patient within the first 3 months of treatment. These patients are studied, and you can see here that the efficacy in terms of spleen length response and the symptom response at week 24 was similar in those patients who received these anti-anemic agents, and very similar to the whole cohort of patients in the JUMP study. And you can see in the right that after week 24, hemoglobin tend to increase and the number of patients requiring transfusion tend to reduce. The second point is on a post-hoc analysis of the Simplify 1. I think this is an important concept. So if you look at the hemoglobin level more than 10, so the endpoint hemoglobin level more than 10, we can see that those patients who started momelotinib with hemoglobin level between 8 and 10 versus those patients who started momelotinib for anemia hemoglobin level lower than 8, we can see that there is a differences in terms of number of patients who reach the endpoint of hemoglobin more than 10. And this has also an implication in terms of overall survival. So basically, this data seems to suggest to start earlier momelotinib, so don't wait transfusion requirement, but start momelotinib with hemoglobin level between 8 to 10. And again, another post-hoc analysis of the PERSIST-2 on pacritinib. This is a cohort of patients who are transfusion dependent. And you can see here that the rate of transfusion independence is quite higher, from 35 to 40% in the cohort of patients treated with pacritinib. So pacritinib is a good drug for controlling anemia and not just thrombocytopenia. And this efficacy on the rate of transfusion independence has been demonstrated in the overall cohort, in the cohort of patients who are Ruxo naive, in the cohort of patients with a very low platelet count, so less than 50,000, and in patients with a low allele burden of JAK2, and in patients with a high allele burden of JAK2 as well. So coming to more anti-anemic agents, I want to quote luspatercept, that is a compound that is already approved for thalassemia and myelodysplastic syndrome. And this is a compound that binds selectively some TGF-beta superfamily ligands. And this is the phase 2 study that included patients with primary myelofibrosis or secondary myelofibrosis into 4 different groups. 2 groups receive ruxolitinib, and 2 groups are transfusion dependent and transfusion independent. So if we look at the result of luspatercept, we can see that the primary endpoint was in the cohort of patients who are transfusion dependent, the achievement of transfusion independence for 84 consecutive days. And this was achieved in 26% of the cohort of patients receiving ruxolitinib, so ruxolitinib plus luspatercept. And using luspatercept as single agent, we can see that the response was mainly around 9 to 10%. So there is an efficacy of luspa as single agent, but adding luspatercept to ruxolitinib, the efficacy is much higher. And if you look on the right, on the result during the entire treatment period, you can see that for those patients who are transfusion dependent and receiving ruxolitinib, the rate of transfusion independence was 32%. And if you look at the secondary endpoint, we can see that the response in terms of reduction more than 50% of the need of transfusion was about 50% in the 2 cohorts of patients who are transfusion dependent, receiving or not receiving ruxolitinib. So on the basis of this result of efficacy, the phase 3 independent study was developed, and this study included patients with a stable dose of ruxolitinib for at least 32 weeks who are transfusion dependent. And these patients received luspatercept on the top of ruxo versus placebo. and the study closed, and we have to wait, I think, very few time for having the final result of this study. Luspatercept is now under investigation in the Odyssey study. The Odyssey study is a study that combined luspatercept with momelotinib and included two different cohorts of patients. One cohort of patients were JAK inhibitor naive, and the second one with patients who were JAK inhibitor exposed. And the combination was momelotinib 200 milligram per day plus luspatercept 1 milligram per kilo. The dose here is lower because it is expected to have a very fast increase of hemoglobin due to the efficacy of momelotinib. Another important drug that is under development is Ritercept, that is a modified activin receptor 2A ligand trap. And this drug is in development in this phase 2 study that included a part 1 and part 2. The part 1 included a patient receiving monotherapy, mostly JAK inhibitor relapsed, refractory, intolerant, and a second cohort of patients who received the combination Ritercept plus ruxolitinib. You can see here some results, and on the top, patient who received Ritercept as single agent. On the bottom, patient who received Ritercept plus ruxolitinib. The light colors means lower dose of Ritercept. The dark colors means higher dose of Ritercept. So if we look at patients who are not TT6, so less than 6 transfusions, receiving less than 6 transfusions, we can see that putting together the monotherapy and combination therapy, the rate of patients who increased hemoglobin was 51% increasing more than 1 gram deciliter, 20% increasing more than 1.5, and 10% increasing more than 2 gram deciliter. And if you look at the combination, the increase of hemoglobin was evident more than 1 gram deciliter in 55.6% of the patients. Now this illustration is for the transfusion burden reduction. The colors are exactly the same, so I will not comment this. And you can see that for TD3 patients in both monotherapy and combination, the rate of reduction more than 50% was in 39% of the patients, and 1 out of 4 patients achieved transfusion independence. And we can see also that in the cohort of patients receiving Ritercept at a dose much more than 3 milligrams per kilo, the rate of reduction more than 50% has been achieved in 62.5% of the patients, and the achievement of transfusion independence in 37.5% of the patients. The last compound that I want to discuss is the DISC-0974. And this is a monoclonal antibody binding to hemojuvelin and block BMP signaling. And this finally, they reduce hepcidin production, increase iron absorption, and lastly, increase the hemoglobin level. This is a cohort of patients with very few patients, and these are the main results. So you can see that in the group of patients who are transfusion independent with low need of transfusion, 1 out of 2, just 5 patients, 80% of the patients became transfusion independent, and the cohort of patients who received more transfusions, so from 3 to 12, about 40% of the patients became transfusion independent. And if you look at the 4 patients who, no, sorry, at the 13 patients who received the combination, the hematological response has been achieved in for 28% of the cases. So these are my conclusions. We know that anemia and transfusion dependency are frequent conditions in myelofibrosis, and they represent an unmet medical need in this disease. We know that momelotinib and pacritinib can reduce transfusion burden and increase the hemoglobin levels. And we now want to see the long-term result and the short-term result of the 3 anti-anemic specific agents, luspatercept, Ritercept, and DISC-0974. I thank you for your attention.
Hello, I'm Ruben Mesa. I'm the president of Atrium Health Living Cancer and the executive director of the Atrium Health Wake Forest Baptist Comprehensive Cancer Center. But I'm delighted still to be able to share with you the role of the current approved JAK inhibitors in myelofibrosis, how they evolved, and how we think about using them in patient care. So here are my disclosures. I've been involved with many different clinical trials. As I think about my career, I saw my first patient when I was in medical school, back with, at that point, a hematology and medical oncology fellow, Ayulu Teferi at Mayo Clinic in Rochester. And from 91 to 2005, we worked together on myelofibrosis under his mentorship and the wonderful MPN team there at Mayo Clinic, and clearly with colleagues around the US, as well as around the world. And during that era, we really had very limited therapies. We still had a limited understanding of the disease. We had aspects, we knew the diseases were clonal, we knew the burden of the disease, we knew patients could progress to acute myeloid leukemia. But the therapies we were able to utilize were either supportive, things like splenectomy, transfusions, irradiating the spleen. There were older medications that we still continue to use for this day, such as cytoreduction with hydroxyurea, not particularly effective in myelofibrosis. And we had had some success with thalidomide and fellow IMiDs having an impact on anemia. But our options were really limited. It was the discovery of the JAK2 mutation by William Vanchenker and many groups around the world subsequently that really was the game changer. One, it gave us a very important insight into the biology of MPNs. Not necessarily as straightforward a story as BCR-ABL and CML, but clearly a very actionable target with overactivation of the JAK-STAT pathway being present for these individuals. Second, it was able to leverage what were evolving JAK inhibitor programs that were already in development for a range of reasons, including autoimmune diseases and others. So not only did we have a potential target, but there were already some candidate compounds in development that I think really jump-started the clinical trial process. Now, I gave a talk earlier this year where I was asked to walk through this, and people would ask, is this a little bit like the Odyssey? And indeed, the Odyssey, for those familiar with the story, is really quite a complex and convoluted story. There's actually a movie coming out, a new version of the Odyssey from Chris Nolan that I think is anticipated with great interest for 2026. But these pathways, just like the Odyssey, were not necessarily straightforward, and such has been the case with the development of the JAK inhibitors. So let's begin with ruxolitinib. Ruxolitinib is the first approved of the JAK inhibitors and really has been the cornerstone since the beginning. This was a compound, originally INCB 018424, that was in development by, at that point, an offshoot of DuPont. DuPont Chemical and Pharmaceuticals, where they were looking at JAK inhibition as a broader platform for autoimmune disease and other reasons. So when the JAK2 mutation was identified in MPNs, they came to then Serge Vershavchuk, Ayulu Teferi, and I about doing a phase 1 clinical trial on their lead compound, of which they had toxicology and other information. Now, ruxolitinib's development in some ways is the most straightforward of the four, having been started by Incyte and really was able to get all the way FDA approved by Incyte. In part, to be able to do that, they were able to leverage the partnership of Novartis, where Novartis would have the therapy really for distribution outside of the United States, with Incyte within the United States. And Incyte has subsequently grown to be a sizable a company in and of itself with a global presence with many therapies in development. Now, the approval of ruxolitinib, which occurred in 2011, was off the basis of the COMFORT studies that I'm sure everyone in this audience has now seen. But in many ways were were really cutting-edge trials for their time. First, these were the first large phase 3 trials done in myelofibrosis. Almost everything that had been done prior to that were really phase 2 studies. So this was phase 3 and Rux versus placebo or best alternative therapy in Europe. And with demonstration of clinical benefit from improvement in spleen and total symptoms. Now, over time, we've recognized that this has been a very helpful assessment of clinical benefit for patients. But this was an evolution. When we first started the discussion with the FDA, they really only wanted to see survival as an endpoint. And why we pushed back on that as a requirement is that the survival with myelofibrosis is both very heterogeneous, as we've all learned with the various prognostic models, but also that with a median survival roughly of 3 years at the time, to conduct a randomized trial with survival as an endpoint really was impractical. It was going to take a long time to conduct such a study. It was going to have people remain on a perhaps inadequately effective control arm for an extended period of time. It would be difficult to maintain patients on the study. And it completely ignored the clinical benefit that patients frequently would experience within just a few weeks of starting use. So even though it's a placebo-controlled study, you really knew who was on the study because people were responding where the placebo patients were not. So the blinding really was not that effective. Over time, importantly, we've learned that there is an impact on survival. And although that was not a primary goal, as I shared with you, or primary endpoint of the study for practical reasons, the reality and every real-world evidence cut that has occurred afterwards really supports this. Why do people live longer? I think it's multifactorial. I think there is clearly a decrease in likelihood of progression to AML, although some patients still can't, but it clearly has a slowing impact on that. Less debilitation, less death from comorbidities, all as reasons for sometimes significant extension of life. Here showing the COMFORT-2 5-year final study results, and again, showing this difference in terms of survival. Now, we have learned over time that ruxolitinib is both helpful, but it's not perfect by any means. And there certainly are individuals that have less of a benefit. In this work with the RR6 model, and there have been further updates to this model, helps to identify those patients that really are less likely to have a good longer-term outcome. In particular, one, if they don't have a good response. Two, if they're not really adequately treated with a sufficient dose of ruxolitinib, and if they have significant anemia challenges, particularly transfusion dependence. So this does help to sort out who are the good ruxolitinib responders versus who needs consideration of a different therapy. And as we look at the data from the other approved JAK inhibitors, this is an important point where both cytopenias as well as lack of response are important decision points in terms of choice of therapy or a change in therapy. The second approved drug is fedratinib. This started testing roughly around the same time as ruxolitinib, but had a more complicated path. It started with Targogen, with the work of John Hood, Katrina Jameson, and others. It ended up then being picked up by Sanofi, which took it into phase 3 clinical trials. There was an FDA hold around concerns around Wernicke's encephalopathy, which we'll get around to in a moment, that I think is both manageable but has a black box warning associated with it. It briefly went back to Targogen, which then was able to partner, and then the agent was bought by Celgene, and then now is commercialized by Bristol Myers Squibb. Approved in August of 2019, the core for the approval was a phase 3 study led by my friend and colleague from Mayo Clinic, Animesh Pardhanani, of 2 different levels of fedratinib versus placebo, and showed significant improvements in spleen and symptoms. And we've seen over time in subsequent analysis this demonstration of benefit. Not randomized data compared to ruxolitinib, but in many ways data that is similar in terms of response rates in two parallel phase 3 studies. Approved both in the frontline setting as well as can be used in the second-line setting. Fedratinib, I think, is particularly helpful in the frontline setting if there's a contraindication to ruxolitinib. I will consider it most strongly in individuals that have had cutaneous malignancies. There probably is a differential that favors fedratinib over ruxolitinib as it relates to non-melanoma skin cancers. So if a patient's already had several skin cancers, I will think about starting with fedratinib. Likewise, if they have failed ruxolitinib, but they have preserved counts, fedratinib is a good option. And we say that off of the Jakarta-2 study, so a trial done by Claire Harrison, myself, and other colleagues. This shows a updated analysis of that study, looking at modern definitions of ruxolitinib failure and response, with around a 33-35% response rate for spleen and symptoms for those that have failed ruxolitinib. Fedratinib is a good and active agent. I think overall, globally, it's underutilized. So I would heavily encourage you to utilize it, particularly for individuals that have preserved counts, that have failed ruxolitinib. It's being used in several combination studies, which is a logical place to look at it as well. This issue of Wernicke's encephalopathy, since the approval of the therapy, there have been both additional safety studies as well as in clinical use. We both monitor thiamine and replace thiamine. I'll share with you that in my practice, I just give patients thiamine. It's a vitamin. It's inexpensive. It's non-toxic. I find if I give them thiamine, it's pretty much a non-issue. So the fedratinib does have some impact on thiamine metabolism, but if you give them thiamine, it pretty much abrogates that risk. The third approved drug, pacritinib, started out as an agent in Singapore from a company there, S-Bio, as part of the Singaporean biotech area. They've been developing several compounds. It was then picked up by CTI, and they helped to lead the first phase 3 study, the PERSIST-1 study, for which I was the PI. There was an FDA hold around issues of whether there was an increased risk of bleeding or cardiovascular events that I think largely we have worked through. The differentiator for pacritinib when it was first being tested was that it could be used in individuals with lower platelet counts that we typically have used with ruxolitinib or fedratinib, which are largely tested for those with a platelet count above 50,000. And now it's both approved and it is commercialized by Sobi. Now this approval was based off of the PERSIST-1. I was a PI on the PERSIST-1 study, served for Sovtek, the PI on the PERSIST-2 study, looking at individuals with a platelet count less than 100,000 with evidence of response. They were able to demonstrate in individuals with significant thrombocytopenia, responses in terms of spleen and symptoms compared to the control arms, as well as improvement in difficult symptoms. I like to share one of the main advantages is that you can really give this at full dose in individuals with significant thrombocytopenia, whereas if you're using ruxolitinib, you likely have dose modified. If we think back to that RR6 model, which I showed you in ruxolitinib, using suboptimal doses of ruxolitinib is probably suboptimal for overall response. So being able to maintain dose intensity was important. There's also a bit of benefit for anemia or less drug-emergent anemia and some improvement in baseline anemia as assessed for these individuals. And part of that, over time, we have come to realize is probably linked to activity against ACVR1, decreases in hepcidin, and improvement in hematopoiesis. And here showing differences in clinical improvement in cytopenic myelofibrosis. The fourth, momelotinib, the most recently approved in the fall of 2023. This started in Australia with a company called Cytopia, then was purchased by a Canadian company called YM Biosciences, then by Gilead, which took it into phase 3 clinical testing. It was unsuccessful at its first run of FDA approval. Additional information was requested by the agency. YM Bioscience took the agent back for further development, and then now has been commercialized by GSK. Momelotinib inhibits ACVR1 in addition to being a JAK1 and JAK2 inhibitor. So it helps to improve spleen symptoms and anemia. And in some ways, for the patient with anemia, has then a role even in the frontline setting for patients that have significant anemia. There is ample evidence to show benefit in spleen and symptoms, but also less drug emergent requirements. So Simplify-1 was the trial. I was the PI on momelotinib versus ruxolitinib in the frontline setting. And you see here less transfusion requirements of Rux versus momelotinib, as well as improvement overall in symptoms. Perhaps slight lean of symptom improvement on the ruxolitinib over momelotinib, but still close. This very important. This in Simplify-1 shows that with momelotinib, a bit like the discussion we had with pacritinib, you're able to maintain a much greater dose intensity so that the majority of patients in the darker shaded bars are able to maintain the full dose versus ruxolitinib, where you see multiple layers of dose reduction, as well as you see hemoglobin levels rise in crossover on this randomized study. The additional study, which Dr. Rostopchik and I led to add additional information for a justification of an FDA approval for momelotinib, was a second-line study of momelotinib versus danazol with an open-label crossover for momelotinib in patients in the second-line setting who were symptomatic. And it was able to demonstrate superiority in terms of symptoms compared to the control arm of danazol, superiority for spleen response rate, and clear non-inferiority for anemia, but certainly leaning toward almost being superior for momelotinib. Whether you see her difference here in terms of transfusion independence rates, as well as after crossover improvements in anemia. So if we think about these 4 agents, they really all play a role. And as someone who actively cares for patients with myelofibrosis, I'm really grateful that we have all 4 agents. We're going to have subsequent combinations. They may fit in different ways with different combinations, but they have different profiles. In the frontline setting, I think about for people with preserved counts, ruxolitinib is the standard. Fedratinib if people have cutaneous malignancies. If they have anemia, I may think momelotinib in that frontline setting. Or if they have severe thrombocytopenia in the frontline setting, I'll think about pacritinib. Any one of them make a case in the second line setting, depending upon the profile for the patient. Now, indeed, as we think about these agents, they all align around their inhibition of JAK2. However, they have additional targets that do reflect some of the differences we see in terms of their profiles that are relevant. As you think about managing adverse events, we clearly manage patients through their anemia. If they're thrombocytopenic, we may consider pacritinib. If they have herpes zoster virus and they're on ruxolitinib, that would be an indication for considering a different agent. All but ruxolitinib have some potential GI impact. I think prophylaxis for diarrhea or nausea is appropriate for fedratinib and pacritinib. And if these end up being unnecessary, then pull them back. The thiamine issues are specific to fedratinib, but I would not let that really be a limiter. If patients take thiamine, it really helps to abrogate that risk. So I've really not had it preclude me from considering fedratinib, but I am mindful to replace that thiamine. Skin cancer, one, it's more common in MPN patients at a baseline, so we should be more mindful of this. 2, with ruxolitinib, if they're starting to get skin cancers, that really should be a consideration for a change. Finally, discontinuation. The issue of abrupt withdrawal of the JAK inhibitors can be present for any of them, but is more tied to ruxolitinib. When switching from one agent to the other, I typically try to get them down on their dose of ruxolitinib to less than 10 milligrams twice a day and then change. So you think about our current NCCN guidelines, again, we consider the use of in the lower risk setting, the data is the greatest for ruxolitinib, or they will include momelotinib if the patient is anemic, although if they're anemic, they're probably not lower risk. And high risk, there's really a case to be made for each of these agents. Now, as we conclude the discussion around JAK inhibitors, we're mindful that there have been many agents that have been in development that were JAK inhibitors that ceased development either because of the competitive landscape or toxicities. We do have some new JAK inhibitors on the horizon, some particularly the Incyte compound and Ajax that have some more specificity to the mutated form, and we look forward to seeing those data with great interest to see if we see differential benefits. Many agents in development, again in combination with JAK inhibitors, none are approved yet, but probably with pelabresib, the most advanced of those combinations, but many others close on their heels. So with that, I'll go ahead and conclude. Clearly, everything that I've shown you is very much of team science amongst investigators, collaboration, both with patients, and as you see, colleagues across, 20 different pharmaceutical companies who have been good partners and who have really helped to advance these efforts forward. And with that, grateful for this opportunity. Sad I'm not there to be able to take questions in person, but look forward to hopefully joining you in person in Paris in 2026. Thank you.
I'm going to talk about novel therapies and future clinical approaches for myelofibrosis. Obviously, I can't cover everything that's going on in the field right now, but I am going to cover what I think is probably most imminent and most relevant, and then at the end, what I think is on the verge of becoming phase 3 in the future. Here are my many disclosures. And I broke it down into sections. So we're going to first start with frontline JAK inhibitor combination therapy. And we heard a nice talk from Ruben, who really detailed the history of JAK inhibitor development by many of us in this room as single agent. And it wasn't, I think, even a surprise back then if one were to imagine a future where that would probably become the backbone of combination therapeutic approaches, which is what we're seeing today in many cases. So you probably would have anticipated I was going to review the Manifest-2 study because this still remains, in my opinion, the most important phase 3 study that is ongoing, I'll point out, so not completed, in the upfront setting, using ruxolitinib as a backbone and pelabresib, the pan-BET inhibitor, as a combination partner in a phase 3 study. And this is the design. So these were intermediate 1, 2, and high-risk patients with myelofibrosis that had not seen any JAK inhibitor therapy previously. They had to have some measurable symptom burden, a platelet count greater than 100,000, so we're already discriminating against some patients that have more advanced disease with lower platelets. And they were randomized to pelabresib, which is 2 weeks on, 1 week off. That was ironed out in the phase 2 study, 125 milligrams by mouth, and then Rux at the label, 1 dose below the label, and then you dosed up the second cycle, which is a 21-day cycle. So 2 weeks on, 1 week off, Rux continuous, and then placebo in the competing arm. And the primary endpoint was classic SVR35 at week 24. And then the secondary endpoint is really diverting from the usual TSS 50, but looking at an absolute change in the mean TSS from baseline to week 24. So what I'm showing you here is the updated results that we presented at EHA, and at ASH we'll present 96 weeks, so this continues to follow through. But I show this slide to make the point, at week 24 there was a statistically significant improvement in spleen reduction with the addition of pelabresib to ruxolitinib versus placebo plus ruxolitinib. And at week 72 that was maintained, 46.3% versus 29.2%. And that's really important because I would make the argument, and I think Claire would agree, that if that was not the same at this point, that would make this whole approach a lot less attractive. So depth and durability. Here I'm showing you that symptom improvement was there. And there's been a lot of discussion about the fact that it is hard to improve upon the symptom burden and the relief of symptomatology with ruxolitinib. But I would argue that you do see that improvement. It's not statistically significant, but again, at week 72, it continues to trend towards the advantage of pelabresib, and it maintains that delta between the two lines with a 2-point difference. So you don't worsen symptoms. If at worst, one could say it's about the same. At best, you get a 2-point reduction in symptomatology. Additionally, we saw improvements in hemoglobin. So at this time point, it mimicked what we saw at week 24. So 16.4% of patients had a hemoglobin response, which was 1.5 grams per deciliter or greater at week 72 with pelabresib and ruxolitinib versus 9.3. And if you looked at the patients who had hemoglobins that were low, less than 10 grams per deciliter, 20.9 versus 16.9. So favoring the combination of pelabresib. And then looking at biomarkers of disease modification, one of Naveen's favorite topics, 51% of patients had at least 1 grade reduction in bone marrow fibrosis versus 28.2% with single agent ruxolitinib. So continue to see deepening of this biomarker suggesting disease modification, and maybe at the panel we can discuss whether this is actually clinically meaningful. But it's still, I think, I'm happy to see that it continues in every facet to favor pelabresib. I would even say the toxicity continues to favor pelabresib. Here you can see the two plots look very similar. We saw this at week 24. We continue to see it at week 72. They're rather balanced, the toxicity profiles between the two arms. You do get less anemia with pelabresib. I showed you that graph. You do get more thrombocytopenia. It's almost always reversible. It doesn't usually lead to dose reductions or discontinuation. And we maintain dose intensity of both the study drug pelabresib and ruxolitinib in both arms. So this was a pretty well-tolerated drug. If people talk about GI toxicity and dysgeusia, I can assure you that it's minimal and rarely an obstacle for most patients. Now, what got attention was an imbalance. We like to use the word imbalance when we can't explain it. An imbalance of patients who developed accelerated and blast phase disease between the two arms. And this is now trying to show you the function of that imbalance over time. So on top, we're looking at a cutoff of March 29th, 2024. That's week 48. And then below, week 72. And what I want to draw your attention to is the numbers of patients who are developing accelerated blast phase disease don't really increase between week 48 and week 72 in the pela arm. They remain stable or the same. Whereas you start to see a continued increase in accelerated blast phase patient development in the placebo arm. So the original small difference, which was not meant to be, we didn't anticipate it and we weren't looking for it per se, but we noticed it and reported it, then really closed, and we did not see increasing cases of blast phase disease. In fact, if anything, in the placebo arm. So there was a late effect of progressive disease with Rux alone. And a very rigorous analysis was done to try to understand why this would be the case. And none of the clinical nor the biologic factors of the disease predicted for this, nor were any of the blasts that had molecular profiling providing any kind of signature that would explain why a BET inhibitor, in this case, would accelerate this phenomena that's seen as part of the natural history of the disease. And we did not see this, I should point out, in the phase 2 study where we actually had sicker patients in arm 3, which was the combination. So this is a little unclear, but continues to be followed very closely with very rigorous analyses to understand if there really is something there underlying that. At the end of the day, survival was not different. Now, some people may look at this curve, and some people do look at the curve and say, well, there's a survival advantage plus pela plus Rux. I think that's probably premature to say. I will say that there's not a worsening of survival. So the blast phase cases did not compromise the survival analysis and the survival benefit here with the combination. And we continue again to follow these out at week 96 and beyond. So that set the stage for a lot of interest in combining these agents up front. And I'm not going to go through the data here because it's not available, but this is the SENTRY study. This is the randomized phase 3 study of selinexor, which was really used primarily in B-cell malignancies and myeloma as an XPO1 inhibitor in combination with ruxolitinib versus placebo plus ruxolitinib in a similar patient population, DIPS1, 2, and high-risk disease, who were JAK inhibitor naive with a platelet count greater than 100,000. Here again, you see the same primary endpoint, SVR35 at week 24, and then absolute change in TSS, which has become an endpoint of interest for a lot of reasons that we can discuss at the time of our panel discussion. But this is an important study. It is it has completed accrual. We hope to start to see some results next year, looking at whether this is a potential agent to be moved to the frontline therapy as a combination partner. So combination up front, is that the way to go, or should we be adding agents to patients who are on ruxolitinib who are failing to be optimized on the therapy? And I have to highlight navtemadlin for that reason. So this is the first study that we did, phase 1b/2 study of navtemadlin, which is a best-in-class MDM2 inhibitor. That is, MDM2 is a protein that's been shown to be upregulated in MFCD34 cells as a consequence of JAK-STAT signaling, and negatively regulates wild-type p53. So inhibiting this protein turns on apoptosis and cell senescence, and has been shown preclinically to be very potent both as a single agent and even more so as combination with ruxolitinib. So here patients were on ruxolitinib. They were deemed to have an inadequate response by the treating physician, and then they could add on navtemadlin, which is given 7 days consecutively at 240 milligrams. Well, recommended phase 2 dose was 240 milligrams out of a 28-day cycle. And that window is set up to allow for recovery of on-target myelosuppression. So what did we see here? First of all, safety-wise, as we knew from this class of agents, we do see GI toxicity. This is manageable if one is aware of it and uses maximal antiemetics and antidiarrheals when needed. It doesn't happen in every patient, but when it happens and the patients are not aware of it and are not managed appropriately, this can be a reason for discontinuation or dose modification. But you can see the frequency of grade 3-4 events were actually quite low. Thrombocytopenia was mostly recoverable. And if you look at the right, you can see that generally speaking, there was preservation of hematopoiesis, both in terms of platelet count on top and anemia on bottom throughout the study period. So we didn't really see cumulative myelosuppression. But what we did see was benefits beyond the stable dose of ruxolitinib. So you can see on the left, further spleen reduction, SVR 35% rate at week 24 was 32%. And if one looks at 25%, whether that's a more meaningful endpoint in this setting is arguable, but that was 42%. But what is, I think, also really interesting is if you look at the doses of Rux, and I like to point this out because I really think it points to the synergy which we saw preclinically with these agents. If you look at the doses of Rux, even at low doses, 5 milligrams twice daily, we're seeing spleen reductions of 39%, 43%. So clearly driven by a synergistic effect with the add-on of navtemadlin. And for anyone who is worried that the toxicity of navtemadlin would impair the ability to enjoy symptom improvement, I think this graph on the right would suggest that's not the case. And there was significant reductions in symptom burden, again, in patient population that was already on a stable dose of ruxolitinib. So this is additional benefit upon the baseline of a stable dose of ruxolitinib. And then, again, pivoting to biomarkers of disease modification by flow cytometric analysis, looking at CD34 cells, which aberrantly traffic in myelofibrosis, we saw very potent and rapid reduction in the CD34 cell count in these patients. And sort of interestingly and provocatively, I will point out, it did seem to predict for or associate with SVR35 responders. So clearing these abnormal cells that are trafficking from the clone, from the peripheral blood, and at the same time driving the spleen down in size. So this informed the ongoing POESIS study, which is an innovative study design in which patients, again, are taken as JAK inhibitor-naive patients, but they're not randomized to the combination of the study drug versus placebo up front, but rather they are allowed at least 18 weeks of therapy on the inhibitor, on ruxolitinib, on a stable dose for a period of time that then allows for one to retest spleen symptom burden by TSS and then determine whether they're suboptimal responders, which is not hitting SVR35 and not hitting TSS50. And then those patients are randomized to the addition of navtemadlin to that stable dose of Rux or placebo with the, again, co-primary endpoints of targeted SVR and TSS at that time point. So this is different. I like the study design because it doesn't assume that every patient needs a combination up front. And the truth of the matter is we do not have baseline biomarkers, whether they're clinical or disease-related biomarkers that help us predict or navigate in a world where multiple therapies are approved, which therapies should be used up front versus as add-ons. I'm going to now talk about imetelstat, but to talk about imetelstat, I do have to point out that the randomized phase 3 study continues and continues to move forward with the prospect of completing accrual and looking at overall survival as a unique endpoint in this field. And imetelstat, of course, is a telomerase inhibitor, which I won't get into all of the preclinical data that would suggest that this is also a targeted therapy and anticlonal, and has data as a randomized phase 2 study for an improvement not just in spleen and symptom, but intriguingly survival at the 9.4 milligram per kilogram dose, which bested 4.7 milligram per kilogram and looked much better than 5 independent studies that would suggest a median survival of about a year to 14 months. And here in this phase 2 study at 9.4, we saw around 30-month median survival. So this study is hopefully going to prove that is true with this drug, and this is a single agent in the relapse refractory setting. So these are the patients that are unlikely to do well and postulated not to do well with another JAK inhibitor. So the best available therapy arm excludes JAK inhibitors, and there will always be some criticism of that decision, but that was the way the trial was ultimately developed at a time when we didn't have multiple approved JAK inhibitors. But the reason why I show that is this slide, because it's the theme of combination. This is the IMPROVE MF study that was presented, at least the initial results were presented at ASCO this year. And this is taking the same theme of patients who are on ruxolitinib and determined to have had a suboptimal response by the investigator, could then add imetelstat. And this is a dose escalation. You can see the doses here, 4.4, 5.6, 7.1, and 8.9 milligram per kilogram, in addition to the stable dose of ruxolitinib. And Rux had to have been on for at least 12 weeks with a stable dose of at least 4 weeks. And the bottom line is these are the numbers of patients that were enrolled. Ultimately, 19 patients across the dose escalation cohorts were enrolled. And I show this just to make the point that these were the kind of patients you would expect to be on a phase 1 study with a dose escalation format with an add-on of imetelstat. Here we're giving it every 4 weeks, not every 3 weeks. The way it's given is a single agent in the relapse refractory setting. And you can see on the right the duration of imetelstat at the time of data cutoff, 25 weeks, so not that long, and number of cycles, 7, and the Rux median duration was about 35 weeks. What did we see most importantly that would suggest that these two can be combined? We didn't see drug-drug interaction, so one drug didn't interfere with the pharmacokinetics of the other drug, and Cmax was reached about 2 hours after the infusion of imetelstat in a dose-dependent fashion, and we didn't see accumulation of the Cmax over time. And then ruxolitinib also followed a pattern that was very consistent with what we've seen with single-agent ruxolitinib PK parameters too. So there was no concern that we were interfering with the biologic activity of these two drugs by combining them, and we did not see a DLT, and we did not actually hit an MTD. There were no grade 5 events, importantly. And actually, the toxicity profile was much cleaner than I would have expected, particularly from a myelosuppression standpoint. You can see on the right, there was only one patient who actually had thrombocytopenia that was considered grade 3/4 treatment emergent, and this is a well-known liability of imetelstat, so this was an interesting finding in itself. And we plot out the hematologic parameters here to get a sense of what the kinetics of the counts were doing during the treatment. We did see some, and this is, I think, a very hard thing to show in a dose escalation, different doses, they're color-coded. Looking at, in an open label study on ruxolitinib, looking at symptom improvement, one would get the sense that at the higher doses, purple, you're seeing more symptom improvement. And on the right, if you look at maximum absolute reduction at any, up to week 24, but at any time, that looks even better. And then on the right, down on below rather, by imaging and centrally read, you can see reductions in spleen volume, and in some cases quite large reductions in spleen volume. We did look at biomarkers, and again, this is early on, so it's a little bit hard to draw firm conclusions. You can see the spectrum of driver mutations and other high molecular risk mutations that were present in the patients that we treated in the data we had at the time of data cutoff. But I like the heat map because it does give you a sense that even in a phase 1 study at rather early time points, we are seeing, in some cases, dramatic reductions or eliminations of subclones like SF3B1, and even high molecular risk mutations like ASXL1. And this is something that we did see in the single agent trial in the phase 2 setting with imetelstat, again, suggesting, and I believe, whether it's actually through telomerase inhibition or not, anticlonal activity. So what's just around the bend? Because those are all the things that we have, either mature or maturing data. What's around the bend? We've heard about today the Insights 33989. This is the monoclonal antibody to mutant CALR in the setting of being expressed on the surface of the malignant cells in conjunction with the TPO receptor. And this is a really elegant approach to targeting this molecular subtype. The FC portion is silent, so it doesn't engage the immune system. There's no threat of CRS. And the preclinical data would suggest it very potently downregulates intracellular signaling and leads to cell death. And I think from the ET data, we're already getting a sense of that as presented earlier today, and we will see the MF data at ASH. So I'm looking forward to seeing what the drug looks like both as a single agent and in combination with ruxolitinib in this dose escalation format. Not to leave JAK2 V617 out, but there are a number of companies, Insights leading the pack in terms of an inhibitor that binds at the pseudokinase domain. The way I think of it, this sort of allows for a more wild-type conformation of the JAK2 protein and restores normal signaling. And this also looks very good preclinically as a selective JAK2 V617F inhibitor, so this wouldn't be relevant in MIPL or CALR. We look forward to seeing some results from this dose escalation study, likely in 2026. The same thing with AGI 11095. So this is the type 2 inhibitor. This is based off of a lot of work that came from Memorial with Ross Levine, with the concept of persistent JAK signaling in the face of type 1 JAK inhibitors, which are the 4 JAK inhibitors that are approved. Again, preclinically, a lot of these things look very potent. But if you've been in the field long enough, you will recognize that not everything that looks very potent preclinically translates beautifully into the clinic. But this one may be different, and we are excited to see what the results look like. Again, I think we're going to have to wait till 2026. And then lastly, I do need to point out another drug that would be around the bend, which is also interesting, nuvisertib. This is a selective PIM1 kinase inhibitor. And for those of you that remember, Novartis years ago had a pan-PIM kinase inhibitor that was a little bit too myelosuppressive. This spares myelosuppression. This drug can be given as a single agent, as we've seen from data so far, without inducing thrombocytopenia, which is the liability of most drugs that we use, and very potently downregulates inflammatory signaling. And these investigators have done some nice correlatives showing an association between the reduction in inflammatory signatures and outcome measures like symptom and spleen reduction. This you'll see moving forward in combination approaches, which is why I included it here. So in the end, there are phase 3 programs which are deserving of mention, Manifest-2 with pelabresib, selinexor with Sentry. We heard from Dr. Passamonte the luspatercept independent study. We'll see results in more greater detail at ASH. The navtemadlin POESIS study, originally the Boreas study was the single agent, and then the Impact MF is the phase 3 study, with the Improve MF being the add-on combination study. And then the molecularly defined approach is a new era of drug development with the CALR antibody, the JAK2 V617F specific inhibitor, the type 2 JAK2 inhibitor, and then PIM1 kinase inhibitor. And these are just some of the many drugs that are in development, but the ones I thought were worth mentioning. And again, I want to thank Claire, Francesco, Naveen, Ruben, and everyone else for including me in this fantastic meeting, and happy to take any questions